So a little bit about the project before we get started. The project had 144 single patient rooms and 44 exam rooms. It was about 557,000 square feet at about $272.8 million. What's interesting, and you'll see some of this when we talk about the room specifically, what created this shape was around how the room was designed specifically, to where we really wanted to open up the views for the patients to the exterior as well as the caregivers from the corridors. So when we started opening up those views and splaying them, it started to create the shape of the floor plan that you're seeing there. So it truly was designed from the inside out to allow some of these views that you'll see further on. So there were 3 floors, 2, 3, and 4 for ICU and med-surg, and then the 5th floor was shell, just to give you some context. A little bit around our basis of design and how we selected our products. A lot of times when you look at flooring, it may just be the aesthetics. It may be under comfort foot. In our case, it was for a lot of children. When we started to look at the flooring, we didn't just automatically start with products and what the latest trends were. We knew we needed to hit these very key parameters when we were. So a little bit of context, we started with our product selection with approximately 20 manufacturers. From that point, we had to really focus on colors that were appropriate for the pediatric palette. And then lead. We did design up to lead silver, and then what the facility was already familiar with. There were a variety of products, as you can imagine, in a building from 1984 that over time had tested multiple different products in multiple areas of the facility that we now needed to go back and see what they were familiar with and understand their cleaning procedures. The products were then evaluated by up to 250 people from patients, families, clinicians, and leaderships. So we did not take the flooring decision lightly, if you can imagine. It was a very key component of our design. When we designed the room, I mentioned the splayed view to keep the outboard toilet out of the obstruction of that view. So that created that opening that I was referring to earlier to give that maximum view. What that also did is we began to really look at how do we zone from a functional and operational standpoint the patient area, the family area, and the caregiver area. We have an individual caregiver alcove at the front of each room to really separate these zones. We did do extensive mock-ups. As I mentioned, all the people that evaluated the products from caregivers, administrators, the designers, the family. We did quite a bit of evaluation, and I'll show you how we did that in just a second. But we really wanted to make sure we looked at all of this performance criteria. As each of those stakeholders come to the table with a different perspective, we wanted to make sure we evaluated and balanced all of that feedback to come to one right decision, not just what the administration liked from a color perspective or what the designer felt was the right choice. We had a very extensive evaluation tool where we looked at all of the warranties, the maintenance, the sustainability, all of the specification criteria for each of the products that we were looking at, as well as some of the visual tools. And so now we're going to share a little bit about those post-occupancy insights that we did find. So I'm done with the design part. Now you can hear some of what we're really here to tell you about is what our clinicians feel about the products and what our environmental services folks really feel about the products.
Thank you, Kristen. And so the goal number 1 was to reduce slips, trips, and falls. And in our 1984 building, the type of flooring had like a high gloss finish to it. And so we did experience some slips, trips, and falls, both with associates, families, and we really wanted to see if there was a way that we could reduce some of that just by virtue of a change in some of the decisions of how things were made. I looked at the incident reports over the last 10 years actually to prepare for this, and the overall number of slip, trips, and falls has decreased steadily from the time that we moved from the old building until then when we're in this new building, although we still fully occupy the 1984 building. So in order to try and tease out that data to find out, what made the difference, it really does make a difference that we've had very few actual slips, trips, and falls in the expansion units, and that's looking at associates and family members that have fallen. It seems to be where they're falling now is outside of the building because of the snow and ice. And then the other thing that was important to us is early mobility. That's a concept in nursing that helps inspire patients to get to recover quicker. And so we get them out of bed, and then we've got to push them around in different areas. And we had thresholds outside of the rooms that would be barriers to pushing a patient in a wheelchair with an IV pole, and it would be boom. Now, okay, wait, let me get over this. So we needed to have a continuous surface. That was important to us as nurses to be able to get our patients to wherever we needed to be. And the other thing that was important to us as nurses was this whole idea, these patients are in the hospital because they are unwell, because they've had surgery, and it's horrifying to push a patient, go, okay, little bump, boom, and they go, because, it's painful to them to hit those transition spots that just jar the bedding. Not so in the expansion. The flooring is all continuous, even into the bathroom. They can roll right into the showers because it has been designed that way. And then the follow-up maintenance and security for that has been something that has worked well with that product. What we noticed that the way that they had to clean in the prior facility was with a wet mop that was, super saturated, and then they would be slinging it, back and forth, and they could clean an entire hallway in very little time in this technique. However, what happened was either they were injuring their own backs slinging this heavy mop back and forth, or staff that were trying to get through that hallway and they were too impatient to wait for it to dry would slip on this now wet surface. So our new products, which Mary again will speak more to, gone are those gigantic mops, and instead they're using something that's smaller so they can both clean just half a hallway at a time, and it reduces injury on their own back, but also leave a space that is prepared, and it dries pretty quickly, so that impatience with waiting for it to be ready to walk on has diminished some. But now the equipment that they're able to use, they're able to get in and out and turn the room around in a short period of time, which makes it useful for us. But the perception of quietness is probably the biggest thing that we've noticed. We hear that from our families, that they are not constantly hearing things transit up and down the hallways. They are in their rooms, and just walking into the room, the acoustics have changed so that they're not hearing the stuff that's being carted up and down the hallway. They don't hear footfalls as they approach. It's not uncommon to come into the room to answer a call bell and they'll go, oh, we didn't even know you were coming, because it really is so much of a quieter surface that anybody who's traveling on is using that. I think we decided there was some decisions made about whether or not we needed the 3 millimeter thickness versus the 2 millimeter thickness. And in some of those testing that were done beforehand, they really looked and evaluated that, and it seemed to, in the inpatient areas, not make any difference in achieving those goals of both quietness and care for. The other thing we measured is, how did staff feel as a result of having to run all over the place and look for supplies in order to care for the patients. And so we then repeated all those studies after we moved, and people said, I'm actually going farther, but I don't feel as tired at the end of my shift. And we have to attribute that to the forgiving nature of that floor that allows them to continue to walk and feel supported. And the only other thing that I wanted to go back and just mention is that in the design of the room, as a nurse and caring for a critically ill patient, this whole idea that we negotiate bedside space for where the parents, they want to be right there on top of their child, and I need to be there on top of their child in order to deliver care. But those, you saw that slide earlier where the color scheme was selected in such a way to define areas. And even indirectly, if I welcome a family into a room and I say, this is, where your child will be, look at this end of the room, which is the family-centered area of your room, you have your own mini fridge, you have your little sofa, but then they stay in that color scheme and they stay out of my way when they are trying to be present for their patients. So, it's interesting how that that one little piece made such a huge difference in how we can work together. And in so doing, it has improved our satisfaction scores, because we're not constantly telling families, you can't stand on this side of the bed, or I can't work, and setting up that adversarial relationship. Instead, on a subconscious level, they are directed to those areas, and they just seem to stay there, and it allows us to get our work done, and it allows them to feel like they are still full participants with their child. And so our goal number 5 was the service inherently is a dirt repellent, but it doesn't serve as a media for microorganisms. That really is something that Mary will speak more to, but I can tell you that as a clinician, you know, we have standards that are defined by the Center for Disease Control about how often we need to wash our hands. So there are hand sanitizer globes all over the place. And so 3 years after we've gone in there, in order to prepare for this talk, I went in search of a hand sanitizer that underneath of it I could find where there was any change in the color of the floor, and I could not find any. So I'm going to turn it over to Mary.
Thank you. Good morning. So from an environmental service standpoint, the selection of the flooring that was put into the expansion, it was a no finish required nora rubber floor. It eliminated the wax use and a lot of complaints from glare from wax. If you have a customer that likes that high finish glossy look, the flooring that was placed down, there is a chemical-free process that we did do on the floor to achieve that wow factor and still make it look like a gloss, and there is no wax at all. The perception of the visual cleanliness scores, we did expect an increase because it's a new facility, the expansion. However, even 3 years after the expansion opened, we're still in the 90th percentile for the patient experience of the cleanliness scores, and it definitely has to do with a lot of the design and the flooring that was placed into the new expansion. So improving air quality. So the flooring that was put down, with it being a no wax product, it's basically chemical free. We didn't need the heavy strippers and, you know, the wax and the baseboard stripper that causes a lot of, harsh smells and odors. So it was able to be cleaned with little more than water. Last year we did obtained the Nora steamer machine that is just distilled water used, and the achievement on that was just overwhelming. We were able to use that machine in real high traffic areas like nurses' stations that were hard to get into with the bigger machines, noisy, and it was able to be cleaned with the distilled water in different floor pads, and it was dry almost instantly. So one of our biggest goals that was met was the return on investment back to our client. So we did have an 11% decrease in floor care supplies, and majority of that was because all the new flooring in the expansion wasn't no wax, so we didn't need to use, like I said, the stripper and all the floor pads, you know, that need to be used for the different types of scrubbing. We also saw a 75% efficiency increase in our labor, and mainly that was because we didn't have to have a lot of overtime to pull in floor care technicians to do flooring on like off hours or when it's a little slower. So not that there's really an off hour at Moore's, but it cleans a lot easier than VCT. Gets scratches in it, and the dirt gets inside of those scratches, and it takes, you know, like the mopping she was saying with the looped cotton wet mops, you know, you need a lot more water to really get it as clean as you need it, where with these flooring, microfiber is the new way to go, and it's a lot less water or less chemical. We do use neutral disinfectant cleaners to mop the floor, especially in the patient care areas, but you don't need to saturate the floor. So operational efficiencies. So the ability to restore the floor, not replace. So one of the funny stories we came across was in the expansion, actually in Ruth Ann's department. We had a patient family that was in there, and the sibling got a hold of a Sharpie marker, a permanent Sharpie marker, and drew beautiful pictures all over the nora rubber floor. And I'm not talking like a couple little pictures, I'm talking everywhere. So we walked in and they said, what can you do? And it was on the chair and all over the floor and the wall. So at first looking at this, if this had been a VCT, we would have had to strip everything down, pray that it didn't get into the actual tile, and it would have been a large process. We were able to go in, and probably within 45, 50 minutes, we were able to restore that flooring to look like it originally did when the family first walked in. So also in our operational optimization, so in the 84 building, it did have a lot of the VCT floors. 4 hours is a long turnover time, but what would happen is we did have a lot of patients that were long-term patients, and when they would leave, basically the floor had to be stripped and refinished. And it's a long process of, scrubbing it and, rinsing it, applying the wax, got to wait for the wax to dry. So it really held up the process of turnover for patients. In the new expansion, we were able to get it down to 45 minutes because majority of the rooms when a patient left just needed a microfiber mopping.
Some of the other lessons learned that we had, we mentioned the 2 millimeter to 3 millimeter value engineering discussions that we had at length. When we did decide to go to the 2 millimeter, we did not compromise any of the acoustics. We did, however, make the change to 2 millimeter throughout the entire facility. We should not have done that, going back and looking. In some of the elevator cabs and the service corridors down in the back that took a lot more of the abuse, the 3 millimeter would have been a much higher and better performance. The facility, after being open and operational, did decide to go back to the 3 millimeter in those high traffic areas. Because they were operational, they used a brand new product, the Nora NTX self-adhesive backing product that was able to be done with a very, very quick turnover and be able to walk on the floor immediately after that replacement. That was not available during the time of our specification and design selection. However, had we been able to use that technology, we could have potentially avoided $1.7 million of the moisture mitigation that you often have to do to the concrete and the testing, which is a huge factor, and I think in any large project these days, especially with the speed of construction, understanding how to deal with the moisture mitigation issue. The installation actually went very, very smoothly. Having those experienced installers is extremely important to make sure your subcontractors use a proper installer and to have that Nora Tech team support. They voluntarily came to the site and monitored the progress because we did not want any issues to come out of there. So that was something, a little extra, that we don't usually see in a lot of our flooring manufacturers. It was extremely appreciated.
Thank you, Kristen. My name is Sandra Soresi, and I am the marketing leader for Healthcare Solutions with Nora. And one of the beauties of working with Nora is we believe very strongly in the voice of the end user. And from a takeaway standpoint, I think what we recognize is that the built environment does support outcomes. And in support of those reimbursement drivers, we know those outcomes are now costing our health systems up to millions of dollars. And we really have to look at flooring as the foundation of the healing environment because it covers every square inch of what we walk on. Evidence-based design was a big driver of this presentation today in the post-occupancy evaluation. And those 8 points that Kristen and the team shared with you are actually from a Center for Health Design study that was done back in 2012. And any flooring can meet those same drivers, but it's a checklist for you. And you have to be able to make informed decisions. And at the end of the day, that's what this is all about. So knowing what a major expense flooring is, and that we need to make those informed decisions. At the end of the day, it goes far beyond first cost. We have to look at that total cost of ownership. And as Ruth Ann and Mary have both shared with you, as far as the direct savings that have gone back to the facility, not just in cleaning supplies and in man hours, but operationally how that affects from a room turnover standpoint. And that drills all the way down. It's all about creating safer spaces. And what we want to do in making informed decisions is we want to make sure for the built environment we're supporting operational optimization, clinical efficiency, safety, and patient and caregiver satisfaction. And as Ruth Ann said, if our caregiver isn't happy, sometimes our patient and their family isn't happy. And that's a direct reflection on those HCAHPS scores. And so I think sometimes, though the patient experience is incredibly important, we really sometimes neglect the caregiver. And that's a conversation that I think you're going to see moving to the forefront more and more.